Hello to everybody. We are then approaching the end of this course, at least in the part of the theory. Then we'll have much more time to practice this afternoon. And you had already a great presentation about what is the value of this course, what is the possible development coming after this course. At the end of my talk, we'll have a little bit of interaction about that, so any kind of question you have on how you can proceed from now on to develop your skills, we are here to help you to build together a personal pathway and maybe a personal curriculum model to face the skill development in this field for each of you. I will spend the last time with you with a brief focus on the D step. So this is a course about the ABCD primary management. ABC is actually the most important part related to airway breathing and circulation management related applications. D is about the neurological stuff. Obviously, D could be the first before ABCD, but usually when D is so much impaired, like a major trauma to our brain, a crash in our head, maybe that we are already dead. That's why D is there, because usually where we can do still something, even in the most extreme situation, is about the respiratory and hemodynamic management, to preserve oxygen to our brain, okay? Provided that all is done, and then to face things related to D can be of a certain value, and ultrasound can be useful to detect something. This is mostly a research area. That's why it's at the end like an optional skill or an optional topic for you to know, because still there is a lot of stuff to be standardized so far, okay? Then after this brief summary about the D applications, we'll have a recap with a simulation case. I will show you some slides and then a video, then that in 8 minutes we resume most of the things that we have reviewed in this course, just to give you a sense on how all of this together can proceed, the ABCD management around the same patient with US doctor in a real tight time frame, confirmed to the timely management of any kind of unstable and critical patient. Given all of that, Dr. Chen, how much time I have, so I just split my presentation accordingly? 30 minutes. Okay.
In Taiwan.
30 Taiwan minutes, not
Yes.
Italian minutes.
No.
Okay, so I will dedicate it not more than 10 to 15 minutes to this topic, and then I will recap. So the D point of care ultrasound application are mostly related to this kind of assessment. It's not the only one. We are gradually developing application, for example, to assess the pupil reactions, or just in patients that cannot collaborate or open the eyes, to assess the midline shift. We are gradually developing a chapter about the transcranial Doppler, selecting the focused applications that could be feasible by an emergency or critical care physician at the point of care, like I've been doing for echocardiography, extracting the focused cardiac ultrasound pattern of application, etc., etc. But this is something that where today most of the literature and the research is focused. That's why I'm reviewing with you mostly this application. The measurement of the optic nerve sheath has been identified as something that could be safe and effectively and accurately done at the backside, and giving us a sense, at least, or an indication of the intracranial pressure wherever this is an element that is needed in our diagnostic differential diagnosis workout. This is a known application by many years, but it's in the early 90s that intensive care physicians like Liechtenstein start publishing data about it and how it could be part of a whole body approach when we have at this step of the primary management or the head step of the head to toe secondary management of our patient. Here you see some of the initial picture coming in these studies demonstrating how it could be easy to recognize a very large optic nerve sheath diameter compared to normal one. In a while we'll see all the anatomical and clinical related issues about this. Obviously it was not only an issue of the intensivist, but radiologists has been demonstrating this kind of application. Particularly at the beginning was more focused on the study of the hydrocephalus of the neonatus or the infant babies. What about the sonoanatomy underlying this kind of application? This is just a few images to just recall how the optic nerve and the surrounding structures are located behind the ocular globe, and they go obliquely to cross matching to the chiasma structure. These again are images to remind you how the different layers and structures are composed. And you see that the optic nerve itself is surrounded first by its internal and inner membrane, that is the pia mater. Then you will have the subarachnoid space, then the dura mater, and then finally the true optic nerve sheath. So there are different layers that are surrounding the optic nerve, and there are layers between the nerve itself and the optic nerve sheath. Here you see some more detail. Why the enlargement of the surrounding structure of the optic nerve are relevant to presume an intracranial pressure growth? Because you see, if the skull is a closed system, when pressure is growing for any reason, you see maybe a subarachnoid hemorrhage, an hydrocephalus, or even a cerebral edema itself, the structure out of the skull will be pressed out and will have an hydrostatic growth pressure transmitted by what is happening within the skull. And so here you will have enlargement of these structures because fluid through the subarachnoid space is coming here, and the edema is coming here through the anatomical structure, and pressure is getting behind the globe with the protrusion of the optic nerve, with the papilla edema, with the flattening of the posterior face of the globe. So all this area is going to suffer from pressure coming from behind. So that's why we could have there some kind of sign about that. This is a microscopic view just to make clear that the subarachnoid space surrounding the optic nerve itself is not empty, but is filled, even in normal patient, of, you see, this kind of septa. That's why this space, even in physiological condition, is hyperechoic. So it's not a virtual space. there is a thickness, a certain thickness of this layer, and when you have not fluid coming from the intracranial pressure growth, it's empty of fluid itself, but it's full of septa. That's why it is hyperechoic. Whilst the optic nerve itself, for its structure, is hypoechoic. These again other views that show what is the optic nerve itself with the central vessel, arterial and vein vessel, and the subarachnoid space and the surrounding structure. This is where the papilla is, and when the edema will make this layer bulging. And this is an MRI view that is quite interesting because helps you to build the image in your brain on how the layers are displayed. So you see here the ocular globe, this is the optic nerve, this is the subarachnoid space, and this you see here the surrounding area of the periorbital fat. So what's happening if we look more in details, matching an MRI and an ultrasound image? You see that the structure of the optic nerve is dark in the MRI and hypoechoic in the ultrasound scanning. The subarachnoid space you see here is bright, as it is hyperechoic. Can you see this profile surrounding the nerve? So this is where the subarachnoid space is displayed with all its septa in that level of the space. And you see that here we are very much helped by the dark appearance of all the surrounding structure and the retroorbital fat. On the contrary, in the ultrasound scanning, the surrounding structure are not dark, but are bright. And this is making this examination difficult on itself, because if it is very simple to distinguish optic nerve from the subarachnoid space, it's not easy to distinguish the subarachnoid space from the retroorbital fat, and the measurement of the optic nerve sheet should be just taken from this minimal hypoechoic interface that you can detect here and you can detect here. So don't measure from here to here, but from here to here, perpendicularly to the axis of the optic nerve. I emphasize this point because I'm sad to say that most of the papers published about this topic have wrong measurements. Please just spend your time to make a review, and you will find that many pictures displayed in the papers are not measuring the right structure. That's why today we cannot say that this is still a standardized technique. Here you see other views, some bulging of the papilla, and here you can see the trilaminar structure very easy. Optic nerve, subarachnoid space, and the surrounding structure, so easy to be measured as well. Here you see a video clip where this is not so easy to be seen and measured. So this is what is more usual coming under your eyes. And you see that we should know exactly what is medial and what is lateral, what is nasal and what is temporal, because we should presume how the nerve is going obliquely toward the chiasma, the optic chiasma, and so we know that the optic nerve to be measured is not the straight structure. The optic nerve and cannot be straight. These are artifacts. The optic nerve is this obliquous structure. We can see just a little piece of it, and if you see, you can hardly see, but you can see the surrounding hyperechoic subarachnoid space, and the measure should be done a little bit obliquous, perpendicular to the real axis of it. Here you see some example of the measurement of it, And you see how it's nice to see, for example, in this study, to see the diameter before and after a lumbar puncture, okay, application. So you see that in real time you can see the variation of it. Sometimes if you are not sure about the measurement, about the structure that you are looking at, you can use a color Doppler just to identify the central vessels and the direction of the nerve. What is the technique? You use a high frequency probe. You can use also the low medium frequency probe, but this will require more skill. So better to use the high frequency probe to look at the details, maybe avoiding this kind of application and doing something a little bit cleaner, not just for the comfort of the patient, but because this will prevent minimal cross-infection chances coming from streptococcus, staphylococcus around, or even C. hepatitis or HIV that could be transmitted from patient to patient through the conjunctival contact. I have not too much time, let me hurry. Just going to the, to at least specify that the measurement is usually performed 3 millimeters behind the globe, because at this level the structures are more flexible, and so the dilation corresponds more to the intracranial pressure growth. But be very careful, because pictures like this that were historical, part of papers about intracranial pressure, are in some way misleading, because if this is surely the optic nerve and the surrounding structure images, this is not. These are the shadows. So if you go too deep, you will measure just artifacts and not the optic nerve itself. What about the cutoff? I tell you to don't rely on what is published so far, because most of the studies are biased by wrong measurements. But it seems clear that if you are at the level of at least 6 or more millimeter, you will find the average standardized as 5.7, like or 5.9, like a threshold above which most of the patient will have intracranial pressure, or 5 millimeter as the limit, where if you have value below this threshold, probably your patient is not with intracranial pressure. But again, be very careful about that. Anyway, we could confirm that if you have value above 6 millimeters, 6.5 millimeters, you are very likely to find yourself above this value, clearly stating intracranial pressure state. This is just a review of the most important studies. So this is a meta-review of what is available, and you will find, you see here, optimal cutoff, always ranging between 5, 5.8, 6 as a reference. In children, for sure, the cutoff is lower, and but not so much lower, and you should consider cutoff values between 4 and 4.5 millimeters, depending on the age of the child. Consider differential diagnosis and false positive, not in terms of the ultrasound measurement. I mean, false positive related to intracranial pressure. Not all the optic nerve sheath enlargements, provided that you measure properly, refer to intracranial pressure growth, but there could be other local problems, neuritis, tumor, etc., that could interfere with the anatomical structure and making them enlarging. I was talking about biases. I'm just reporting this paper among many, where you will see this kind of picture. You see that here we have any trilaminar appearances, so we are not sure what we are measuring. Here we are measuring the optic nerve, we are measuring the optic nerve plus the subarachnoid space field of fluid, and then dark, or we are measuring just a straight shadow. Who knows? I don't know. And many papers are just measuring things that are not clearly defined. So again, don't rely on them. You see here another example. What are measuring here? We are sure that we are measuring at 3 millimeters, but what we are measuring? Shadows, optic nerve, or optic nerve plus subarachnoid? Then the true optic nerve sheet diameter reference. Again, or you will find a picture like this one where the optic nerve is clearly obliquous and the measurement is clearly not perpendicular to the axis. So this is an obliquous measurement that is not reliable, because the optic nerve is always going obliquously to the chiasma structure. Again, don't rely in this kind of images. I'm here just mentioning some of the data coming from our group working with the NASA, with the astronauts, because I feel that they are those ones that went most appropriately and accurately toward the maturation. They use a lot of experimental model in the space or after the flight, the space flight, or during the simulation, you know, with this kind of rotating structure, because these are very nice models to see how the pressure can grow in the brain. And you see here that in their studies that I personally also review, and I'm working with them on making a more accurate research of that, you see that this is the image that we should always looking at. Not this one, not this one, not the other, but this structure where all the layers are well depicted. And you see that even from this not published data, the threshold to be taken as reference is quite a little bit higher than what usually published by the paper with the biases that I mentioned. How we can solve this? Apart from measuring better the anatomy, being sure of what we are measuring, anatomy and not artifacts, the true anatomy layers that I show you, we can use other findings like tortuosity of the optic nerve, flattening of the posterior area of the ocular globe, the bulging of the papilla, the enlargement of the optic nerve itself that is suffering from some kind of intrastructural edema. You see that not only the optic nerve sheet is enlarging, but the optic nerve itself, etc., etc. So the key point where we are doing some study, if some of you is interested, could help us in doing this, is to identify not only the optic nerve sheet diameter in a proper way, that's the minimum to be done, but the patterns of findings accompanying the optic nerve sheet enlargement to prove that the patient has really an intracranial pressure growth. So that's for sure the future of this technique. A more integrated clinical pre-test and post-test assessment in terms of probability that a certain threshold has something to do with the intracranial pressure, plus a pattern assessment. That's the future of this area where we are working on. And that's it. So let's use the last, I have still 10 minutes, is it? Okay. 1 minute. And I'm just using to show you the last video. So, in the last 6 minutes that I will be left to show you the video, I will show you this kind of simulation case study. I'm just introducing it to make it more comfortable when you will see all the problems coming along this patient. This is a traumatized patient that we're bringing to the emergency room, and from the very beginning we'll start having airway problems. getting desaturated, so we will state A failure. It is a didactic case, so this problem on purpose will have A problems. We'll try to identify a problem and to solve A problems. Then this patient will have B problem, we'll try to identify and to solve B problem, etc., etc. So I'm just starting this slide presentation with few slides just for you to get comfortable with the dynamics of the video that you will see. So you see here we detected the hypoxia. The patient is not going to be ventilated and ventilable. You see that here we have a transthoracic image of the lung, chest wall, pleural line, the two ribs with the shadows, the pleural line. So we'll have no E lines, you remember, the lines of the subcutaneous emphysema, regular pleural line, not sliding, but lung pulse. Can you see? Tick, tick, tick. And A lines, meaning what? No subcutaneous emphysema, lung not collapsed by free air, neither collapsed by free fluid, immobile and dry. Okay? And this is how we'll try to work out with images. This is the M mode with the lung pulse pattern. We'll assess beyond the lung the cervical area to see what is going on, why our patient cannot be ventilated, what is obstructing, and we'll find an hematoma that is creating dislocation of the trachea. We'll decide to perform a cricothyrotomy in emergency to save our patient, and we'll perform this. You see here, this is a longitudinal cervical view. This is the cricoid cartilage, first, second ring, thyroid cartilage. This is the needle getting through the cricothyroid membrane. And these are at least 5 centimeter depth. So apart an open surgery, no immediate closed procedure could perform this safely because the trachea is really too far from the skin. Here we'll have a transversal view. We'll see in the video in a while. Just I want you to keep familiar first with these images. After solving the access to the trachea, we'll check where before there was the lung pulse, what is now? The lung sliding. So we'll describe this image like no line, regular pleural line, with lung sliding and A lines. Sonographic description, suggesting what? No subcutaneous emphysema, lung not collapsed by free air or fluid, mobile and dry. Clinically suggesting what? A good ventilatory activity with a patent airway access. This is the clinical consequence. So sonographically, no line, regular pleural line with sliding sign and a line. Sonographic description. Physiopathology, no subcutaneous emphysema, lung not collapsed by free air or fluid, mobile and dry. Physiopathology. Clinically, patent airway. Okay? You see how the process is. Because my clinical question is now the airway patent for this patient? And so on. We'll go through probably with B, assessing for free fluid or for tension pneumothorax. We'll go through the heart and IVC to assess what kind of shock this patient is facing, etc., etc. We'll see in a while in the video because I'm running out of time, and we'll comment the video itself and not the slide set. Just a second, and we'll see the video. You can find this in YouTube if you type USDLS or fast ABCD. Okay, so you could find this also to enjoy a little bit. So you see some introductory pictures, slide, about what we have been overviewing, the ABCD model. The evolution from fast IFAS to fast ABCD. Obviously, here we are talking of a trauma patient. the case is about the trauma patient. And you see here the scenario. So the injury, okay, so you saw that the patient is coming to the emergency room with problems, but not so much unstable. But immediately after, start to get having problems. So getting more and more hypoxia. Obviously, we start from the A, and we assess that there is an A problem because the patient cannot be ventilated. You see here the lung scanning, no A line, regular pleural line, lung pulse, A lines. So the lung is not moving. We proceed with all the steps that are well known by all of you, trying to intubate 1, 2, 3 times after obviously inspecting the oral cavity. I will not mention all the ATLS at single point. Let's think that we're doing whatever is needed. The patient has still no ventilatory activity. You see here that we are 2 minutes, maybe 1 minute of pre-hospital scenarios, and this is the 1 minute we are dealing with this patient. Okay, no way, the patient cannot be intubated, cannot be ventilated, so we decide for an emergency critical thyrotomy. We are a team with a nurse, a surgeon, and a critical care physician all working together. You could have different roles in this team, and as we saw that the trachea is very deep, we have no other way than guiding the procedure. Don't look to the sterility aspects because are not the objective of this didactical movie. This is the longitudinal view that proves that we inserted the needle and then the rest of the catheter in the proper position. We have done some study not yet published with pigs, and we can talk about this, and we saw that a transversal view could be the safest and the most accurate to guide this procedure compared to the longitudinal approach. You see that still the lung is immobile, no A lines, regular pleural line, lung pulse A lines. As soon as we'll connect the ventilator, if our procedure was correct, we would expect what? A sliding sign, okay? So we prove in real time that our maneuver was efficient. Now our patient has airways problem solved, but is getting hypoxic again. What's going on? Let's check on the right chest. No A lines, regular pleural line, sliding sign A line. So no pneumothorax, no hemothorax, no subcutaneous emphysema, also in the basis, and the lung is being ventilated. No real major problems. Let's look at the left side. Here the situation is quite different. No lines, regular pleural line, but no sliding and no lung pulse, with a stratosphere pattern in the M mode. So our suspect is immediate about a pneumothorax. We are looking at the border of pneumothorax, and we find here you see the sliding, here not. This is the lung point that is telling us what is the limit, what is the border of the pneumothorax. And we can see in real time that the border was shifting laterally. So with the tension pneumothorax under our eyes just growing. We decided for an immediate chest decompression. In the mannequin you have just one hole to get through. But the ultrasound can help you to decide even the best anatomical places where to perform this procedure that would be blind otherwise. We see clinically that the thorax is being re-expanded, but we'll check better with ultrasound what's going on. Let's have still a look at the right, where still everything is in order. And let's look in the left, where before you had no sliding, no pulse with the A pattern, now you have sliding sign with a B pattern. What is about? The lung is being reinflated, not anymore pneumothorax, but signs of lung contusions, okay, like we should expect there. Now our patient has AB and SALT, but is getting hypotensive. Why? We look at the heart is small and hyperkinetic, no cardiac tamponade, the IVC is flattened, and we are looking for an obvious cause of hypovolemia, that is the presence of fluid in the abdomen. Then, while we are preparing the team for an emergency laparotomy, we do all the rest. We perform a centrovascular access, that you know that in emergency situation is where more complications are occurring for the stress, the rapidity that is requested to the operator, etc., etc. And you see that guiding this procedure with ultrasound is make it not just rapid and fast, but safe. And immediately after the procedure, the operator is using ultrasound to detect if we had accidentally created any pneumothorax or hemothorax. And you see that right side is still without finding of free air or free fluid. So the central catheterization was well performed safely. The IVC is being refilled, and our patient is getting stable at this point. Obviously, the destiny now will not be the emergency laparotomy, but the CT scan. We are completing the primary management. You see the optic nerve assessment, pupil reaction reflex assessment in case your patient is not opening, cannot open for some periorbital edema, the ocular globe. An immediate assessment of the midline position. You see the absence of midline shift. Again, this B part is more under research, so just take it as an optional. We are starting the secondary management, where we use ultrasound integrating our head-to-toes assessment through head, neck, thorax, abdomen, and limbs. But our patient suddenly become hypotensive again. What's going on? No tension pneumothorax, no massive pneumothorax. So let's look at the heart. No cardiac tamponade, not rupture of the heart, but an hypokinetic small left ventricle and right ventricle with an increasing amount of fluid in the abdomen. Obviously, our patient is getting hypotensive because he's hemorrhagic, and he's getting hemorrhagic because he's bleeding within the abdomen, within the peritoneal cavity. So obviously, now an emergency laparotomy is what is required to stabilize this patient. So here the story ended. So we relaxed, the patient was saved, and now he's safe. And I think that this is, forgive the limitation because this was produced within a congress, was not in a studio with all the details, just was an immediate real-time performance during a workshop, and we recorded it. I think that there are, if I have still 2-3 minutes, then I'm finished. Something is important about the time first. You see, 8 minutes 35 seconds. Let's say that with the sterility procedure to be set up rapidly, we should have spent 10 minutes, okay, instead of this 8 minutes something. Let's take off the pre-hospital timing of 1 minute, 1 minute 30 seconds. So finally, this is an 8 minutes management. If you try to count how many clinical questions we set and how many answers we gave with ultrasound about A, B, C, D, you will count not less of 40 questions and answers. We can review, but you can imagine how many we had. So try to think that in 8 minutes, with a clinical assessment integrated with ultrasound, we had more than 40 answers. So I think that there is no way to think that ultrasound slowed the process, but made it more accurate in getting findings. What else we could be have been using instead of ultrasound to come so accurate in say no pneumothorax, no pneumothorax, or no subcutaneous emphysema, or that the tracheal tube was well positioned, the centrovascular access was well positioned, no iatrogenic pneumothorax coming from the catheterization, the presence of fluid in the abdomen, the cause of the shock not obstructive but hypovolemic, etc., etc. So what else we could have been using? X-ray, yes, but there was the time to use X-ray, 8 minutes? Not at all. You know that to perform an X-ray and to have an answer to an X-ray, 8 minutes are not enough in any kind of setting, okay? But if we should have had time where X-ray could have given something more of ultrasound about the airway and breathing or C assessment, there is no application that you saw where X-ray is performing better than ultrasound. Today we have evidences that ultrasound performs, you remember yesterday in my lecture, ultrasound performs better, more accurately than X-ray to assess all the problems we saw. Where ultrasound cannot replace X-ray in the primary management are essentially one main application and one maybe optional. And one is related to the pelvic assessment. So ultrasound can see diastasis of the pelvis, conjunction, can see rupture of the iliac bone, can see a misplaced bladder, but cannot give us the whole view and the deep view that X-ray can. So since pelvic instabilities creates hemodynamic instability, the integration of X-ray in the primary assessment is essential when pelvis is involved. Then there are other issues about the thorax where X-ray can obviously give us, like the mediastinal enlargement or other few things, where X-ray can provide us with some information more, but don't lose time to make an X-ray if you have certain signs of massive hemorrhage within the abdomen, and just start stopping the bleeding, not losing time to make your further diagnosis. What else? The CT scan. There was any time to use the CT scan here? Not at all. That's not at all, because we should have scanned a dead patient with this kind of airway, breathing, and circulation instability that on purpose we created. What else we have not been using? We have not been using X-ray, CT scan, what else? It was not on purpose. A student one day showed us that we didn't use a stethoscope. So please keep using the stethoscope. This is our message. But just to provoke you, where the stethoscope would have been giving us something more than what clinical examination plus ultrasound gave us. You have an idea? About saying the airway obstruction? No. About saying pneumothorax, hemothorax, lung contusion? Not at all. I showed you yesterday that paper, among many, proving that stethoscope is very much less accurate than ultrasound compared to certain physiopathological and sonographic syndromes. I just would tell you that where stethoscope is superior to the ultrasound, maybe just the bronchospasm detection, because ultrasound cannot see bronchospasm, but can tell you whether the bronchospasm is in a wet lung or in a dry lung, that you know that's make a huge difference. So our message is keeping collecting the story, keeping looking at the patient, visiting the patient as you are doing, keep using the stethoscope, but don't stop of making an examination that is not integrated ultrasound, because ultrasound is making your management, I hope that the message here is quite clear, faster, not slower, more accurate, not misleading the diagnosis. Particularly, you remember yesterday I mentioned in terms of sensitivity. So helps you to rule out false negatives, okay, and to refine the true positive. of your diagnostic workup. And this is a procedure that is finally safe and is making everything you're doing, particularly invasive procedures like cricothyrotomy, like thoracocentesis or chest decompression, like vascular catheterization, quicker and safer, okay? And if all of what you are doing is more accurate, is faster, and is safer, finally the outcome is not only for the patient and yourself, but is for the system. And then I want to give you a final message. You remember yesterday the global view, the socioeconomic analysis of the healthcare needs throughout the world. If we are using methods that are not just more accurate, faster, and safer, but are more cost-effective, our healthcare system could provide quality, okay, with less resources, not just less time and more accuracy. And to make it like that, more cost-effective, means to create an healthcare system that is providing quality care in a more sustainable manner, and then we empower the accessibility to our system. And we have to solve the big problem of accessibility at global level that I highlighted yesterday in my introduction lecture. Okay, that's it. I hope that I imagine that there are a lot of questions. We'll have the time in this afternoon during the hands-on. If you have some urgent question, I'm here to welcome you while there is the break of the lunch. I hope that this helped you to summarize a lot of the chapters that we'll be reviewing, and particularly to give you a sense on how this can be feasible. It can be feasible. How it can be accurate, how it can be effective in terms of clinical outcome and in terms of cost of the service that you are providing. So thank you very much for your attention. The course is not finished. We'll have the other practical session that at the end of the course we can still give you some clue about how and what to do after this course. This course, just a point, is releasing to you an attendance certificate. Sorry. You will not have to pass any test because Dr. Chen told me that some of you is anxious about being tested. You will have only a questionnaire to ask you if this course was useful to you, and you will have, because you attended this course, an attendance certificate from WINFOCUS that has an international recognition. Wherever you go, WINFOCUS today is a knowledge. Whatever specialty you will be dealing with, emergency, critical care, surgery, internal medicine, this certificate will give value to your curriculum. For everybody, anybody of you that would like to upgrade an attendance certificate to a competence certificate, we can give you guidelines to tell you requirements to get practice and develop your skill in that, and then to be undergoing a certification examination that your group could be doing to yourselves maybe in 3 months from now, okay? Then, as the previous lecture showed you, there are also more complex and long pathways like fellowships. WINFOCUS is also doing, partnering with organizations that were mentioned before. So these are 6 to 12 to 24 months programs. But for an immediate competence-based modular program about these skills, we can provide you with indications about a 3 to 6 months plan that you will be doing most with the self-assessment in your hospitals if you have not locally WINFOCUS trainer, but with a remote guidance and overview from our trainers, and then in 3 to 6 months you can come back here or in other WINFOCUS training center to get a competence-based certification that many hospitals, many countries are recognized to allow you to formally perform this kind of procedure and be also reimbursed as part of your clinical activities. Okay? So thank you very much for your time and attention.